I'm your host, Dale Sherbeck, and welcome to the HQ podcast. For those tuning in for the first time, the HQ is a podcast serial produced by CHA Learning and is your trusted source for important conversations on healthcare issues and topics from those that are leading and impacting the health system. Together, we'll explore these topics as we continue to learn together. CHA Learning is the professional development division of Healthcare Can and is uniquely Canada's only national fully online learning provider serving all of healthcare. So please check out more about our learning programs and services after this episode and discover how we collaborate with health leaders and organizations like those we feature on the HQ to empower healthcare professionals with the knowledge, skills, and relationships to impact health system improvement. So thank you, listeners, for joining me today as we continue our series on planetary health. The topic of supply chains became a critical issue during the pandemic as countries and organizations tried to procure essential equipment and supplies. In this context, it became a political and policy issue around the world, and certainly here in Canada, and it gave reason to many who had hitherto perhaps not really thought about where medical supplies and equipment came from to ask some hard questions, including why are we so reliant on other countries for things so essential to our healthcare operations? Increasingly, it has also elevated the importance of discussing those uncomfortable questions of where have we outsourced our production, and what are the labor conditions and regulations in other places that govern the manufacture of such ubiquitous things like gloves and masks. Our listeners may recall the great conversation I had last year with HealthPro and HealthProc Europe leaders around sustainability and the impact of healthcare on our environment and the role of procurement professionals can play. Through it all, it's clear that we have a problem and that healthcare is a massive part of this problem. And as you hear from today's guest, the issue is not just with the emissions and pollution being created by our healthcare institutions. The use and disposal of products is just at one end of the supply chain. But what about the other end of that chain? What is feeding this consumption and the throwaway approach in healthcare? And does it need to be this way? And again, what can we as leaders do about it? So I'm truly thrilled to have what I believe will be an eye-popping conversation with a visionary and passionate leader who has seen our supply chain from beginning to end, who has been leading to make changes in this space for decades, Dr. Mahmood Bhutta. Mahmood is the inaugural chair in ENT surgery and the professor of sustainable healthcare at Brighton Sussex Medical School in the UK, and an honorary consultant and the clinical green lead for University Hospital Sussex. As you will soon hear, he has a long-standing interest in environmental and labor rights harms caused by medical supply change. So hi, Mood, and welcome to the HQ. It's a tremendous privilege to have you join us today and share your extensive knowledge and experience on this very, very important topic.
Thank you, and thank you for having me.
Yes, so maybe Mood, I know that you've shared this with me before in terms of our pre-conversation, but your personal story and journey has and continues to inspire many who join this movement to address planetary health and sustainability. So maybe if you wouldn't mind sharing, that with our other listeners here, what got you involved in this and your interest in labor rights?
Sure, thank you. It was somewhat by chance, and perhaps somewhat I was destined for this. My family, actually, I'm British and born in London, but my parents are from a place called Sialkot in the north of Pakistan. Now, Sialkot actually produces 70% of the world's surgical instruments. Those going to health systems all over the world. Many will be rebranded and resold to us under different brand names, but that's where a lot of them are manufactured. Now, some nearly 20 years ago, really now, I was traveling through my ancestral home, and one of my cousins, knowing that I was planning a career in surgery, I wasn't a surgeon then, said, do you want to see how surgical instruments are made? Because obviously that was part of the normal business in that town. I was interested, but what I saw shocked me. In essence, these instruments are largely made under what we would call sweatshop labor conditions. These people are working 13 hours a day, 7 days a week. They get paid a piece rate. They don't get paid a regular salary, so they have to work. Many of them, if they fall ill, they'll take sort of advances in their salary, and they effectively end up in indebted labor. And the working conditions are really pretty horrendous. They are working on grinding machines with forges where injuries are not unusual. And then sometimes those injuries are quite severe and life-changing, where there's no real social security. And in addition, of the 50,000 laborers that are working in this industry, several thousand are children, some as young as 7. I've seen with my own eyes 7-year-olds working on grinding machines to make these instruments.
Wow.
The average age of starting the industry is 12. So this sort of just starts me asking not just about surgical instruments, but what is it with our medical supply chains that has engendered this throwaway culture where we want things effectively as cheap as possible, and we don't really ask questions about what that means in the real world.
Wow. That would be life changing to see that. I think, pull back the curtains. Um, so yes, I appreciate that. That's certainly fueled your curiosity about, so many more parts of this. So, and you use the language about a throwaway or disposable culture. So maybe define that maybe a little bit more detail for us. I mean, what is it that you're describing in that? I mean, obviously some things are intended to be thrown away or need to be, but in terms of your use of it or just finding it in this space, what do we mean?
Yeah, I mean, I think healthcare is particularly guilty of this throwaway culture. I mean, those of us who work in healthcare, I mean, I'm a surgeon. I see it with my own eyes, the huge volumes of things that were thrown away. So after every operation, there are bags and bags of waste of things that we're throwing away. Um, if to put it in context, we have some data from the NHS, the National Health System in the UK, where look, what we do in the UK, I've seen health systems all over the world. In high income countries, we all seem to be doing the same thing. 3/4 of everything we use in healthcare is thrown away. The vast majority of that coming from hospitals. In the NHS in England, that amounts to this is just medical waste. I'm not talking about waste like paper and so on. Medical waste is 240,000 tons every single year. I mean, that's huge volumes that are being thrown away.
Wow.
And obviously that comes with a carbon footprint. It comes with, other environmental harms because of the production of materials, the extraction of resources from our planet, the pollution from putting these chemicals that are required to manufacture these sorts of things. So that's the scale of the problem. Now, people might think, oh, well, it's got to be that way. It's safer to throw things away, but that's simply not true. Of course, it's true for some things. If you're talking about a needle, for example, taking some blood or a cannula stuck into someone's vein to deliver some drugs, at the moment we are not suggesting that we're going to be reusing those. And certainly a long time ago, maybe 50 years ago, those things were reused, but obviously we know about bloodborne viruses, so we're not suggesting those things should be reused. But
Hmm.
it's so much that is thrown away that simply does not need to be. I'll give you some examples from the UK. I'm afraid we still use the majority of disposable drapes and gowns. In fact, most of the world does for surgery. These are the drapes we put on the patient, the gowns that we wear. Around 3/4 of everything we use in the NHS in England is disposable. That's 93 million pieces of plastic drapes and gowns that are thrown away. If we move to entirely reusable, we'd have 1/3 of the carbon. We have 48 million electrosurgical pieces of equipment. These are fine pieces of electrical equipment used to dissect in surgery. Many of them are used once and then thrown away. We have bizarrely nearly 6 million scissors that are used just once and thrown away. And you know where those scissors are being manufactured. They're being manufactured using sweatshop labor in the ways that I've highlighted.
Wow. So, and how did we get here? I mean, did we like what's feeding this? You know, this culture that you describe.
It's a complex problem, but I think at the root of it is probably our drive for safety and in particular concerns about infection. And those are, of course, valid concerns. And historically, I think it's true to say that some of our concerns around infection were not being met. But now we have systems in place. But we've overshot. There's no doubt about that. Often related to health scares. So some of the examples I can give you there is back maybe 30 years ago, this new virus we became aware of called HIV, obviously the virus that causes AIDS. And I
Yeah.
remember as a child, I'm certainly of that vintage, that there was a lot of scare that we were all going to die from this virus and it was going to kill everybody and we had to be scared. Now, at that time, people started to get worried, and they started, for example, to wear gloves whenever they're contacting patients. So we saw a huge increase in the amount of gloves at that time, despite the fact that, of course, HIV is not spread by skin-to-skin contact. So wearing gloves is completely unnecessary. We know that now. But that is one example of what's been triggered. We've created these cultures. I mean, I don't know if anyone's been in healthcare, but people are wearing gloves to the extent that even the public now think, oh, health workers should be wearing gloves. But gloves are dangerous. Gloves are potentially covered in bacteria and they spread bacteria. Clean hands are what we need. The only purpose of gloves is to examine, for example, cavities that are full of bacteria, such as the mouth or, some perineal regions, areas that are high in bacteria before washing our hands. And for that example, gloves. We use 1.7 billion gloves in the NHS in England alone. This is prior to the pandemic, and that's enough plastic to just about stretch to the moon. We know that 60% of that glove use is inappropriate. It's habitual. People have just started putting on gloves, even to move a patient. So this has fed this fear. Then we saw other problems. We saw, of course, the pandemic, the COVID pandemic, where health systems around the world were telling us to wear all this personal protective equipment. The thing you highlighted in your introduction, where suddenly we became aware, it was so visual what we were doing. But this problem existed before. It was exacerbated. Now I can tell you all the latest evidence, and to be honest, I said this even at the time, shows that we didn't need to wear all that PPE. It was completely unnecessary. We should have been washing our hands for sure. Possibly we should have been wearing masks, and even that's questioned. But all that PPE for a respiratory virus, a virus that is spread by us breathing on each other, what was the point of that? For some things like Ebola, maybe, but it spread this fear. We've had other scares. So in England, we've had something called mad cow disease. I'm sure some of your listeners
Yeah.
are aware of that. That's caused by a misfolded protein, a prion, which in some genetically susceptible individuals can cause irreversible brain damage. Now, that came around in the 1990s in England, um, and we think it. To be honest, it was historic. That there was poor processing of meat. There were some systems that were not in place, but we also had not got our systems in order, and so we had inadequate or inconsistent, I should say, sterilization of surgical instruments, and that together with this threatening misfolded protein meant that people started to say, let's just throwing surgical instruments away rather than actually try and reuse them. And let's stop all sterile services, which used to exist in all our hospitals. And that became a cultural norm. And that's why we now think it's easier to just throw those instruments away. But I've told you already what that means. If you throw things away, you want them as cheap as possible. And if you want them as cheap as possible, maybe that leads to children making these products as cheap as possible. So these scares come and they drive these changes in behavior and they drive this culture that leads to disposable. I mean, I could go even further. What else has driven this? It's our economic models. I don't pay for what the health system does. The state pays, or perhaps in other countries, the insurer pays.
Yeah.
So I don't pay. And let's be honest, there are incentives and barriers to people's behaviors. And if I don't pay, it's okay to throw it away. It seems so, but of course it's not okay to throw it away. And then some of the companies, I'm afraid, look, there are good medical companies out there, but some medical companies quite like this idea. Hey, if you throw my products away, maybe I can sell you some more. So, of course, that's the capitalist model, which is built on the idea of perpetual growth. We have to keep selling things and we have to keep. And so, if you throw things away, that really helps me. So, we have some bizarre things where we have some electrosurgical products, the things I mentioned before, that will cost what, £600? What would that be? 800 US dollars. And they're classified as single patient use. You will use it for maybe an hour or two and then you will throw it away because it's certified that you cannot reuse that again. And that's simply not true. There is only one reason.
So there's a lot there in terms of what you're describing. I mean, certainly there's I guess a reactionary culture that's bred on fear, as you describe, in terms of when things happen, we respond out of I guess, an abundance of caution, um, perhaps, and that perpetuates this other, um, consumption and repeat sort of approach. And I guess there's a public perception in some of that as well, which is, you know, especially, I guess, in the most recent example we have of the pandemic, where we expected people to be wearing PPE, because that gave us a sense of safety, um, and that everything would be okay. And then as you described, there are the economic sides of these things, and then there's um, the medical industrial complex, if I can use that word, right? Uh, which sort of feeds, I guess, this need on the one hand. So, I mean, where do you focus in all of this? I mean, in terms of breaking apart these things that are all sort of feeding into this culture.
Yeah, where do you focus? I'm afraid all of it. I wish it was one simple thing that we could say, hey, that's the critical piece of the jigsaw. And I think that's why it's such a complex and difficult problem to fix, because it actually requires multiple people. If you speak to clinical people, many of them say to me, hey, look, we actually want to reuse products because we are disgusted with what happens here, but we can't change it because the people in procurement are buying these and the companies are doing this as well. Um, so there's that aspect to it. Then the people in procurement say, "Oh no, we can't change what we buy because the clinical people tell us that's what they need." And sometimes the companies will say, "Well, no, actually, we're just selling to you what you guys are asking for. That's what you're asking for." So it's kind of a very, very complex problem with multiple different players. So we need to tackle each of those. So, I can talk to you about some of the things we could do and what I'm trying to do. Uh, First of all, for example, with infection control, we need a measured and sensible response to this. You've mentioned some of the perceptions. The perceptions are not just in the public, but also within healthcare staff. So
Sure.
within the public, we know that if you go for a vaccine, I googled sort of vaccination images, and I found that I looked at the top 100 hits, and we found that the first 80, or sorry, 80 of those top 100, people wearing gloves to give a vaccination. And that's simply against World Health Organization guidance. You don't need to wear gloves. You're not in contact with any bodily fluids. But this perpetuates the idea. Obviously, during the pandemic, we also saw people going shopping wearing gloves. So they expect health workers to wear gloves. And actually, people need to think, no, that's not right. I want clean hands. Clean hands are much better. That also needs to permeate through to healthcare staff. As I mentioned, people wear gloves inappropriately, but also infection control leads, many in hospitals. I don't mean to be derogatory, but some infection control leads don't actually understand their own science because often they are appointed to these positions. And certainly in the UK, every hospital must have an infection control lead.
Yeah.
And they are then tasked and put in this difficult position sometimes where they must make decisions and make sure patients are not at harm. And in some countries, there's a litigious culture as well. If something goes wrong, you can be held accountable. So what's
Yeah.
the easiest? The easiest thing is to say, let's throw it away. So in a way, there's a void. There's a void in the infection control guidance where we need some sort of national bodies to say, hey, this is what we say is safe and correct. Because most infections are not caused by a product, they're caused by a failure of process. If you follow a process correctly, you will be safe and clean. And we know that from multiple studies that have been done. So that's the first thing. We probably need some leadership and some clear direction in infection control, and that's been lacking. And I've been speaking to senior academics in infection control. I can tell you they're all behind this. They think their own system has gone bizarre and led to a bad a bad reputation for infection control people. So that's the first thing is just bringing that national guidance. In terms of economic models, we really need to question the idea that it seems cheaper to throw things away. I chaired a national report into surgery being a particular exemplar, something called the Green Surgery Report. Your listeners, if they're interested, can look it up. You can Google it. You can download it from our website. That's an evidence-based review of what we can do within surgery. But as part of that, we looked at the economics of green. We looked at nearly 150 case studies that reported across the academic literature and online. And what we found is in every single case, they've reported that being green saved money. So this idea that it costs more if we're going to reuse is simply not borne out by the evidence. There will be examples, of course, where it costs more, but in
Sure.
general, we're going to be saving money. In my hospital alone, we've just done a few things, maybe 3 or 4 changes, and I'm saving £250,000 every single year. So that's what, $300,000 every single year just from doing those things. We also need to change the way that we count economics. So rather than compartmentalizing it in time and in location, we say, hey, we need to meet our budget this year. Well, actually, investing in a higher quality, decent product designed to last hundreds of years, surprise, surprise, costs a little bit more up front, but you are going to save over the long term. Investing in a reusable drape and gown might actually cost the operating theatre apparently a little bit more because it's a higher quality product, but actually you're not accounting for the waste that was disposed. And when you account for that, we know that it usually costs more. The NHS in England has actually found that reusable drapes and gowns cost the system 50% less. So that's the economic models. We can also move to something called economic servitization. So for electrosurgical products, we can say rather than buying lots and lots of these products, we're just going to buy a service for this particular electrosurgical product, say something called a harmonic scalpel or an electrodissector. We will buy just that service. Now, if you want to keep on supplying lots of these and us, we throw them away. Okay, we're not going to pay you anymore. Soon as you do that, the companies say, okay, we will make our product designed to last. We will make sure it's high quality. We will take it back at the end of its life. So that's a different economic model. And
Hmm.
then, of course, that infrastructure that we got rid of, for example, for surgical instruments, we need to rebuild that. We need to go back to, I rarely say this, back to the good old days where we had the infrastructure to enable reuse, high quality, and we need to look at new models of cleaning and sterilizing things. So we're still using the vast majority steam sterilization, something that's been used for hundreds of years. Is basically a steam pressure cooker to clean everything. And it's good, but not every material withstands that. And there's new things such as ultraviolet light to decontaminate things. We're using that in my hospital. Game changer. So cheap, so safe, so carbon friendly.
Yeah, I was just watching an ad for a car that had an electro or ultraviolet glove compartment, I guess, so that you could sanitize your cell phone. But I'm not sure how necessary that is on a day-to-day basis. But yes, I think others are certainly seeing these opportunities, and why not sort of invest them in other parts of our sectors. So I mean, and I think I think largely, I think what you're describing here in very detailed terms, right, is what our previous guest, Dr. Hussein Malou, was talking about, the triple bottom line, right, right, and that if we're only looking at one of these economic pieces of measuring cost, right, we're missing the bigger picture. So, and so, yeah, I think you've made it very clear that we're missing, yeah, we're missing the big picture by just looking at the cost of buying something and what it costs them to get rid of it. But so, I mean, you said that you've made some changes within your own organization. I mean, how did you, I guess, get people's attention in that space and motivate them to make some of these changes, or was it something that you were able just simply to do?
Um, it's of course always good to bring people on board. I mean, I think we actually start from a good point. Multiple surveys of healthcare staff, including in England, but also in other countries, have shown health workers really do care about this stuff. They don't want to destroy the planet. I mean, um, shall we say, most people who work in healthcare are emotionally intelligent. They can see that there are harms, and we shouldn't harm where we can try to prevent that. So that's a good starting point. People are on board. It's just they don't know how to tackle a very complex system. And what I found is that when you enable that voice and when you say, hey, can we do things differently? People suddenly come forward and say they do want to support it. To say it's always easy, no, of course not. I've been very fortunate in my hospital. There are people who are really on board, and and my infection control team are very much on board. In fact, I would say my infection control team is pushing it way further than I would have thought because they've actually said, no, we just don't need to do these things, and we really care. So that's a good starting point. Often it's just finding someone, to be honest, who's willing to say this is wrong, to take things forward. So for example, we've changed to reusable instruments in my specialty ENT, and obviously I tried to push that forward. There was a little bit of uncertainty about infection control, but when I said, oh, infection control, I'm very much on board. they were very much on board. I've used to reusable nasal endoscopes using UV light, as I mentioned. Ophthalmology also moved to eyes have also moved to reusable instruments, and that's because one of my colleagues was very supportive. Um, so these are the sorts of changes that we've made. Our procurement team have also been very much on board. But I don't want you to think that this can only happen in one particular hospital. It just needs leadership. So we actually, just 2 months ago, launched something called the Circular Economy Healthcare Alliance. And I said, hey, let's get some hospitals together that say we will try to always buy a reusable version of a product wherever possible, because we know that a reusable product saves between 38 and 56% of the carbon. There's analysis that show that. So if you reuse a medical product, we know you're going to cut the carbon by a third to a half. There's no other strategy I can think of that will reduce the carbon by that much. And that takes account of all the sterilization, the transport there, the transport back. So that's what we should be aiming for first of all. And obviously, it then links to all the other problems I mentioned, the race to the bottom with labor rights, the problems also with resilience in our health systems that you mentioned at the beginning. Why have we not got these products ourselves? These circular economy healthcare lines include five major hospital organisations in the southeast. So it's myself, but University Hospital Sussex on the south coast of the UK. It includes
Hmm.
Cambridge University Hospitals, and it includes three major hospitals in London: Imperial, Chelsea and Westminster, and UCL hospitals. The collective purchasing is in the millions and millions, but we are sending a clear signal to industry that this is what we're planning to do. Now, the truth of that, it's still being worked out what that means, and over the next year or two, we will try to embed this as much as possible. But I've already had a number of other hospitals across the UK coming and saying we want to join as well. We believe in this idea. So it is the willing is there. The difficulty is in enacting that. But if you get everybody on board, then I think, and clinical people and procurement people and infection control people, we definitely can do this. In addition, I've been speaking to the Greener NHS, the government in the UK, and they are also looking at their strategy as well. So I'm hopeful that we will have something there. The reuse agenda is really what I'm trying to push for.
Wow. So, I mean, I guess, w- I mean, you're filling a space yourself in terms of your leadership and helping people to ask questions that they perhaps never thought to even ask before, and then you're gaining momentum. I think through your leadership and examples that you're providing. So I think you're certainly painting a very clear picture about how you make large scale change, but and I know there's a lot more to be done, but but it's it's optimistic. But what about those other actors and agents within the system that simply just don't know what they don't know, right? Um, right they've gone through medical school or some other clinical development process, and this is what we use to do this procedure. This is how we are supposed to do this procedure. This is the way I was taught to do it. This is the way I was shown to do it. I go to my procurement, people and say we need another 100 of these because we've used up the other 100 that we had. So, and the cycle just continues. So how do you disrupt that? Or how do people ask what they don't know?
Sure. Like I said, I like a challenge. Um, I think what we should do is we should recognize, I mean, the young health workers, I think they're very much on board with the idea of climate change, and then it's here and it's something that's really important. So let's use that enthusiasm to try and drive change. But we also need the older individuals who remember what it was like before, because I actually speak to medical students. I teach medical students at my medical school, and I tell them it wasn't always this way. It was this, it used to be this way, because as you say, they don't understand that. But the people who've been around a while say, "Oh yes, I remember that," and those products were so much better because of a better quality because we weren't throwing them away. So it's a bit like we need to go backwards. My milk is now delivered in a bottle by an electric cart, which sounds very modern, but actually that was what happened in the UK in the 1970s. And so we need to go back to what those days is. But we have a memory because we have the older individuals. So there is that. But we need to drive all the other things. We need governments to come on board with this. So I'm very glad that you've invited me to speak to this audience. It's an international, it's not a UK audience. But also, I've been speaking recently with the government of Norway, with the government of Sweden, and I've been speaking with senior health leaders in Denmark. They are all on board with this because needs to be an international movement if we're really going to try change. So we need government on board as well, and we need industry on board. And we want to reward industry that says, okay, we are on board. We're going to make a high quality, reusable product as it used to be, because you can do that. Any company where there is a reusable version to be made, are you telling me we cannot make that? We can put a man on the moon, but we can't make a reusable electrosurgical product. So by changing the market, that's why I'm creating the Circular Economy Healthcare Alliance. We've made a clear statement that we are trying to commit to this. So if the medical industry comes forward and starts to make reusable products, we will do that. And that's what I'm speaking to governments about, to say, I want you to come on board and say that is also your strategic priority. Because if we change the economics to favor reusable, higher quality products as it used to be, then that will definitely drive the market.
Are there, I guess, from a procurement perspective, procurement professionals or associations or others in that space that are also adopting, I guess, this sort of reusable sort of space and just saying, this should be our first order of business in terms of when we source things, or are there questions that they should be asking even about, you know, places of origin, like in terms of where things are being made and other parts of that equation too?
Yes and no. Yes, in my organization, we do. I work very closely with the procurement people because we need to, and we have a working group that includes the procurement, includes the infection control, includes clinical leaders. And my procurement lead, he's fantastic. He's actually constantly scouring to find where these reusable products are. And there's actually very few of them available because it's just not in the market. But we're trying our best, and that's what the Economy Alliance includes people from procurement. So yes, is it widespread across the whole health system? No. And that's why I'm speaking also with something called NHS Supply Chain, which is the largest single supplier, so logistics agency, to say, I want you to embed this into your policy, that you will, in your future contracts, be buying reusable products. And that's kind of what we need to get to. So the whole system is favoring that change. That's where we need to get.
And in terms of, I guess, that global system changes you're describing as you're trying to, get your message out, or share your research and experience with other countries and organizations around the world that can certainly be part of a larger movement. I mean, what is there another, I guess, space that can help convene that or ignite that or harness that, to create that more global awareness in terms of how um, we do this?
I think the more people that speak about it, the better. Obviously, the Green Surgery Report is something that sort of mentions this, and it should have a global audience. I can tell you that I am speaking regularly at conferences, but speaking is not enough. We need action, of course. I have audiences of hundreds, sometimes of thousands, listening to these ideas. So spreading the word is enough, but could we have a pan-European movement? We've already got something called a European working group on ethical public procurement that's been looking at labor rights for some time. We've tried to harmonize things. And one of the questions you asked me is, should individual procurement people be looking at labor rights harms? And I actually say no to that because it's too difficult for an individual procurement person, A, to understand the complexities of what's going in their supply chain, and B, to have the power to change it as one organization. These are large organizations. We actually need governments to get on board and to say, actually, we are going to make sure that anything that comes into the health system is actually not produced under these bad labor conditions. I can give you an example of that.
Yeah,
One
please.
big example I haven't mentioned is around gloves. So I mentioned we use too many gloves, but actually during the pandemic, we found where the majority of gloves were produced. Well, actually, I knew already, and I'd highlighted issues for some time. 70% of all the world's gloves are manufactured in Malaysia. Many of the others are manufactured in China, where we actually have very little visibility of labor rights. But in Malaysia, the vast majority of workers packing these gloves in the factories are migrant workers. They've come from Bangladesh and Nepal, typically. And our survey, we actually surveyed 1,400 workers. We found that about half of them had paid illegal recruitment fees for this golden opportunity. They are desperate for work. So they will pay these recruitment fees to come and work in these factories, typically $2,000. And I don't know if you can imagine what $2,000 is to someone from Bangladesh or Nepal. Some of them had paid up to $5,000 in Bangladesh, where people are really desperate for work. Some of them had sold land because this was their golden opportunity to sort of help get them out of poverty. When they arrive, most of them typically work 3 months without a single day off. They will have their passports held for safekeeping, which basically, in essence, means they are not allowed to leave the factory. They are transported by factory transport to accommodation to live in factory provided accommodation. None of the accommodation historically was fit for purpose. The worst I've seen is workers living in shipping containers. So for 3 years, they would live in shipping containers and be transported and work 13-hour days, 7 days a week in these factories producing these gloves. And there were quite bad mental health issues. So it was endemic abuse of migrant workers. What has happened there is actually I highlighted those issues some years before the pandemic, but I was actually threatened with legal action for highlighting these issues by one of the major suppliers of gloves. But I'm glad that during the pandemic it was highlighted. And credit must go to my colleagues who work in law and human rights, particularly someone called Andy Hall, who's been a real pioneer in this, who really raised these issues with governments and highlighted that what they were doing was illegal. It was against the law to be using forced migrant labor procuring things. And it was actually the US that took some of the first action. Canada did as well. But the US is the single biggest purchaser of gloves. And they ended up banning 5 gloves, including Top Glove, the world's largest manufacturer of gloves. I have it on authority that Top Glove probably lost around $750 million in revenue as a result of that ban. And only when they modified their worker conditions did they actually get the contracts back again. As part of all of those companies working together, we got over 150 million US dollars repaid to these workers in their illegal recruitment fees, both those who are working there now and those who had worked there historically. That was a condition of them being able to supply again. So that's the sort of level of action that we need. And I'm proud that the US took that action, and I'm proud that other countries have taken that action as well. So it's not just it's the whole system is broken. So we need people at the end sort of saying, hey, I don't need to wear gloves, and modeling that behavior to protect our planet, obviously reusing whatever equipment they need. But we also need governments to take action to build, for example, the infrastructure that allows us to reuse medical equipment, steam sterilization, those sorts of things, the policies that drive this change, including your procurement rules. And we need them to take action when there is abuse against workers worldwide, to say this is not acceptable. We will not buy these products. That's a condition for supply.
So, kudos to you for your own participation in that, and helping to raise, I guess, our collective consciousness about, the issue, and which has led to change. But I'm wondering, like, in our desire to right wrongs, right? Do we sometimes really understand, I guess, what the real issue is in some of these cases? So, governments see it, a miscarriage of justice in terms of the way gloves are being manufactured in other places, and our role in that, and they change that behavior, and they, wipe their hands, and it's like we're heroes, we've done the right thing, and we're moving on. But the fundamental parts of the culture, I guess, that you've been talking about through this have not necessarily been changed. And so, there's another medical device or product that is, symptom of the same, ills. It's just happening in another place.
You're absolutely right. So I don't want to paint, oh, there's good guys and there's bad guys, and everyone in the West is in a rich country is a good guy. That's absolutely not true. We've created the problem. We've asked for things to be as cheap as possible and disposable as possible. And I know from speaking to surgical instrument suppliers in Pakistan that, the issue I've highlighted, they say, we have no ability to change this. All you ask for, all you ever ask for is the cheapest possible price. There was even something which I'm embarrassed to say happened in the UK, something called a reverse auction, where basically you bid against each other. When you get to the lowest possible price, that's who we will go with. That is now, I'm glad to say, no longer happening. When you drive down prices and you don't care, then that is what you're going to get. So you're right. We need to deal. So that's why I'm trying to deal, however successful and unsuccessful I've been so far, with the fundamental underlying problem with our throwaway culture and all the disrespect it does for everything. It disrespects the money we spend on healthcare because we throw that money away. I've shown you that we save money. It disrespects our planet because I've already told you we know that you save between 38 and 56% of the carbon if you're just measuring carbon by not throwing things away. And that's not to talk about all the other environmental toxins, the hundreds and hundreds of toxins that go into every single plastic product, for example. So let's not, well, I'm not even starting there. And of course, then we throw away human dignity. If you want a high quality product designed to last thousands of times, you respect the worker that made it because that requires craftsmanship. And that worker, I promise you, can be in Pakistan because those workers are making the highest quality surgical instruments that are rebranded and sold to us. Why don't we just respect them for what they are, great at craftsmanship, pay them a decent wage, and what, surprise, surprise, we'll also get a higher quality product. I can tell you that's something I want to.
Well said. So yeah, well, I think those are things that we can aspire to, and a collective, you know, change in thinking in terms of what we value, really more importantly, right? So, and I think parts of what you've been describing too. I mean, through the humanity of this, I mean, it's the humanity of the people who manufacture the products that we use, and understanding where they come from and who's involved in this. But I also think that you're also describing, even in right, in terms of how we present our healthcare system to those that we serve, the patients and families, right? The humanity of not necessarily being behind a glove or a mask or a gown, right? And the human touch, I think, is it's also been described in some of our conversations, is also threatened, I guess, by some of these behaviors and actions.
Yeah, indeed. And I can tell you, since I've worked with the issues with gloves, I cannot put on a glove at work, which I try to do very rarely, but I cannot put on a glove at work without thinking someone has probably suffered to make this. So you're right. It's just about creating better systems, more humane systems, more respectful systems that actually work for everybody. And of course, these problems are not unique to healthcare. I'm afraid the whole of high income countries have become very attuned to a disposable culture for so many things that we buy. And actually, we just need everything to be made more respectfully in terms of, a high quality product designed to last. And in many cases, I'm afraid things have plateaued. We are now buying things that we really don't need, and the things
Yeah.
that we need can be made really well. And those things that we really need should be made well and should be designed to last for a long, long time. Just bringing it to healthcare.
Yeah, well, for sure. I mean, I'm, one of my passions is food, and I certainly, I hear the stories here in Canada when, you know, uh, uh, you know, a food producer, right, shifts its market or its manufacture from, you know, making tomatoes, like Heinz was making tomatoes in Southern Ontario, and moved it, back to the United States where it could be made cheaper, right? Or, you know, just down the road from here in Ottawa, where we had a Hershey's, factory that was making chocolate bars, and it was relocated to Mexico, not because it wasn't making good chocolate here, but because they could make a chocolate bar for 5 cents less. And we put a whole town out of work because that was its own industry, and we just don't measure those costs, right? And we as consumers want a chocolate bar that's 5 cents cheaper, without recognizing, what's really at stake in all of this, and what can we do? Is it worth paying that extra 5 cents to keep our brothers and sisters and communities, right, employed, and keeping our resilient economies in place here, as you described as well.
Indeed, I agree. I think there are different systems that we can look at and the total cost of everything. But when everything is outsourced, it becomes invisible. And so we don't see all these hidden costs for everything that we do.
So, I mean, based on what you've shared, I guess I'm wondering a couple of other things. What is the threat to our healthcare systems themselves if we don't get this right and make the changes that you've been describing? And secondly, if were had a policy magic wand in your hands, what would you? I mean, I think you've alluded to some of it, but certainly, cast your spell. What would be the thing that you would ask us to do to create a sustainable healthcare system?
Sure. So sorry, could you just remind me what was the first part of your question in terms of?
So, what is the threat, right, to our
Oh,
healthcare
that's
systems if we don't get this right?
sure, sure. So I think I've alluded to some of it already. What's the threat? Oh, well, we continue to throw away money that we didn't need to. I've already mentioned, I think going green is almost always going to save us money. I don't know about your health system, but our health system likes to save some money because we're in a bit of trouble. And I imagine most health systems around the world would like to save money. So we're not going to have the health system as good as it could be because we're throwing money away and not using it efficiently. There's that. There's the resilience issue that I've already mentioned. We keep throwing things away. Eventually, we will not be able to get the things that we need, and our health systems will collapse. It's just a matter of time if we continue down this way. What else? How should a health system really be contributing to environmental damage, the greatest threat to human existence that is currently recognized? A health system should not be part of that. You cannot call it a health system when it is contributing to the destruction of health around the planet. So there's that as well. What does the future look like? A health system cannot be doing that. And of course, related to resilience, eventually all of our products will run out and we won't have a health system at all. So those are some of the threats that we have, I think, if we don't get it right and we don't question what's going on. The second part of your question, remind me again. Sorry, I can only think of one thing at a
It's
time.
okay. The big question. So, your policy magic wand,
Policy magic wand. Okay. Yeah, I wish I had one of those. So I think with a lot of these things, this can seem so big. This climate change thing is huge, and people think, "Oh, I don't know what to do. I'm hearing all these different things." So I try to keep the message simple, not because I think the solutions are simple, but I think because that first thing, reduce and reuse, there's so much we have not done that we can do. So some of my academic research, I'm a professor of sustainable healthcare. So I'm not just practicing, but we're doing the research. And we've done analysis of carbon footprints of various products and so on, just to evidence what I'm talking about. So what I'm talking about is based upon evidence. We know that looking at the carbon footprint of the most common operations performed in the NHS in England, we can reduce the carbon footprint of the products used by 14% just today, just by people changing what they're doing. No magic solutions required, no changes. It's just stop doing that and do this. So there's so much we can do. That opportunity to reduce and reuse has not been maximized. So I think that's really what I want to push. And that is at multiple levels. It can be at an individual level. Hey, I don't need to wear those gloves because actually nobody's telling me to wear those gloves. I'll follow World Health Organization guidance on when you need to wear gloves, which is expected contact with bodily fluids. That's one thing. What else? If you're a surgeon, I won't open things unnecessarily because I might not need them. So that's reduced. Wherever there's a reusable version, I will change that. Then there can be institutional levels. So there can be things like the Circular Economy Healthcare Alliance. We want more organizations to join us and say, hey, we're going to try and work this out. How does this happen? How does this work? We need industry to come on board and say, hey, we're going to create the products that you need. And we need, as I've mentioned, governments to come on board and say, yes, we will support that. So that magic wand is multiple organizations, but for me, should be embedded around the first thing that we should try to do, which is maximize that reduce and reuse agenda, because that's where we have not lucked out. And because my passion has always been about labor rights issues, and that's where it started. I mean, don't get me wrong, I definitely care about the planet. I mean, that's always been part of the agenda. But that labor rights issue, we should say we are not going to buy any products made using that are not meeting international labor organization standards for the production of these products. And that's a clear line. So when companies fail to do that, we will call them out for breach of contract and we will fine them or we will stop buying from them. And at the moment, no one, other than a few examples, such as gloves, which had a a huge effect. No one has been willing to say that because I'm not prepared to negotiate on labor rights. That's just the minimum bar that we set. So those are the two things I would say. Minimum bar for labor rights, otherwise we don't buy it. And we need to work towards that. We need honesty in companies to say what they're doing to achieve those. I'm not
Yeah.
naive. We can solve all of these things. And the other thing is let's all unite around that reduce and reuse agenda, wherever you're working, in institutions, governments, or as an individual.
A lot of wise words and sound bites in terms of what you've shared. But I guess, um, you know, is there room within your alliance for, Canadian organizations in other countries to join you in this space?
Please. Yes, of course. It's not an exclusive membership. Well, it is exclusive. It's exclusive to those who want to create the change. That's it. That's all you have to do. Join us. There's no sort of the idea that I know what I'm doing. Please don't think that either. We're making it up as we go along, but that's what we need to do. But driven by a common agenda, by a common desire to make things better. So anybody and everybody, please join us.
Thanks, Mood. So yes, maybe you can share with us a few of these resources and ways that people can learn more about this and get in touch with you and your alliance and learn from, I think, some of the great examples that you've shared yourself and provide hope, right, to many who want to make change but don't necessarily know where to start. I think you provided an inspiring set of lessons and examples where where people can sort of emulate them and get involved.
Sure, we'll be very happy to share the links and engage in conversations. So thank you for inviting me to this.
Yeah, thank you, Mood. Any other final words for you then before we close for this first chapter?
No, I guess just sometimes it feels daunting, sometimes it feels difficult, but all we need is actually like-minded, committed individuals, committed to their ideas and their ideologies, and we can overcome anything. So yeah, let's do this together.
Thanks, Mood. So, wishing you great success in the work that you're continuing to do in the United Kingdom, and thank you again for sharing this with all of our listeners here in Canada and around the world.
Thank you.
You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.